these CT scans to train AI for early pancreatic cancer detection.
Good afternoon, everyone. My name is a PhD student at Johns Hopkins University. Today, I will talk about how we use synthetic tumors as a kind of time machine to rewind late-stage tumors in CT scans, so that AI can learn to detect early pancreatic cancer that really appear in clinical data. Why we deal with pancreatic cancer? Pancreatic cancer is one of the deadliest cancers. Early detection makes a major difference. When we catch it late, the 5-year survival rate is only about 7 to 10%, but if we detect it early, survival rate can rise to 40 to 45%. Unfortunately, early tumors are extremely hard to see. Even experienced radiologists detect early pancreatic cancer with only 33 to 44% sensitivity. This motivates the need for AI that can reliably detect small tumors, especially those under 2 cm. But here's a core challenge. There is a huge data gap in medical AI. Early pancreatic tumors are rare, and most CT scans show disease only after it has become large and advanced. We cannot go back in time to scan the same patient earlier, but would we really want to detect a tumor's months or years earlier when they are so tiny? So the key question we ask is, how can we teach AI to find tiny early tumors when we don't have enough data? Our answer is simple. We cannot go back in time to rescan the same patient earlier, but we can simulate how tumors grow, how they deform nearby organs and vessels, and then generate synthetic tumors on CT scan that look like early disease. These synthetic tumors act like a time machine, move backward and forward through the stage of tumor development, allowing AI to learn from early patterns that do not exist in the original scans. Here is the technique behind this time machine. We do 2 things. First, we simulate tumor growth over time using a mathematical model called the cellular automata. This model lets us create many possible ways a tumor might develop and interact with nearby tissues. Second, we map these simulated tumors onto CT images using a generated model. Here's a diffusion model. So the AI can generate what early tumors might have looked like on real scans. With these 2 steps, we can model tumor evolution in both directions, forward in time and backward in time. This is why synthetic tumors used as a time machine for AI training. So let's talk about cellular automata, which is a mathematical model that uses simple rules to simulate complex systems. Each cell can be in a certain state, for example, tumor or normal. At each time step, the state of each cell is updated using simple rules that depend on its neighbors. Even though the rules are simple, the system can show very complex behavior. This makes cellular automata a good choice to model tumor growth, which depends on local interactions between tumor cells and nearby tissues. You can think of this like a complex game of life, but now the game is tumor cells growing inside a pancreas. To simulate how tumors grow, we define 3 simple rules. First, growth. A tumor cell can continue to grow if it still has space. Second, evasion. A tumor cell can expand to its neighbors. Third, death. When the tumor becomes too crowded, some cells may die. By applying these 3 rules over many time steps, we can create many possible tumor shapes and stages, from early to larger, more advanced tumors. Now that we can simulate tumor shapes with a cellular automata, the next step is to make these shapes look like real CT scans. To do this, we use a diffusion model. We condition the diffusion model on the tumor, duct, vessel, and organ shapes produced by the cellular automata. The diffusion model then generates a CT images that matches these shapes in a clinical and realistic way. This gives us the basic tumor appearance, But to make the synthetic scans truly useful for early detection, we also need to model the subtle changes that radiologists look for. Earlier I talked about the basic tumor growth rule. Now I want to show the important extension that makes the images more realistic. Mask effect. In real CT scans, a growing tumor doesn't simply stay in place. It pushes the surrounding tissues and vessels. So we add a mask effect rule to the cellular automata. As the tumor grows, it applies pressure to nearby structures. Organs, shapes, and boundaries become suddenly formed. Vessels can be shifted or partially encased. This allows our synthetic tumors to show the same geometric cues radiologists use every day, such as distorted autonomy. Another very important sign, especially in pancreatic cancer, is duct dilation. We model this explicitly with duct dilation rule. When the tumor presses on or blocks the duct, the upstream portion of the duct gradually becomes wider. This means our synthetic images capture not only the tumor itself, but also essential secondary signs like duct dilation that are critical for detecting small early-stage pancreatic cancers. Now let's look at how synthetic tumors actually help the AI model. First, small tumors. Synthetic data improves the AI sensitivity for detecting small tumors, which is less than 2 cm, by 5%, increasing the performance from 89% to 94%. With this enhanced training, the smallest lesion that AI can detect was only 2 mm. Next, synthetic data for argumentation. Real-world tumor datasets are often biased. For example, about 65% of pancreatic tumors occur in the head of the pancreas, while only about 1/3 appear in the body or tail. Small tumors in the body and tail are especially underrepresented and easy to miss. From our error analysis, we found that the AI is affected by this imbalance. It often misses small tumors in the body or tail. With synthetic tumors, we can directly address this problem by adding more small tumors in these underrepresented regions during training. This targeted augmentation helps the AI learn from the cases it struggles with the most. Last, we look at how synthetic tumors help the AI generalize across hospitals. Imagine we train our AI only on data from hospital A. It has a specific patient demographic, its own distribution of sex, race, age, etc. It uses certain CT scanners and imaging protocols. The AI can perform well in hospitals that look similar to hospital A. But if we apply it directly to hospital B, which has different patient demographics and different CT equipment, performance purely drops. A major reason is that we have very few or no tumor labeled scans from hospital B that could train AI. Our solution is to use synthetic tumors to break this gap. Hospital B may have many normal CT scans, but very few labeled tumor scans. So we treat these normal scans as canvas. We take normal scans from hospital B. We generate synthetic tumors directly on these scans, and then we fine-tune our AI using the synthetic tumor scans together with the normal scans. This lets the AI adapt to the style and the characteristic of hospital B, such as its patient population and its scanners, without requiring real tumor annotations from that site. In our experiments, this synthetic fine-tuning significantly improved pancreatic cancer detection on external hospitals. More details, such as the results, will be presented in the session of December 2nd, 1:30 p.m. in room E353B. So in summary, synthetic tumors let us create realistic, small, and diverse training examples that currently datasets lack. They help the AI detect small tumors, learn from its mistakes, and generalize across hospitals, making early pancreatic cancer detection more reliable. Thank you very much for your attention. I'm happy to take any questions.
Questions from the audience? Would you like to come up to the mic? meantime, I just want to commend you for recognizing a couple of things: vessel encasement, which is an important part of pancreatic fibrosis, and also the cheating code is ductal dilation, something that we use clinically. One of the questions that I was going to ask you is, how early do you think the synthetic analysis can help lead to the diagnosis? I know that's like very clinically relevant, but like as we know, as you stated, pancreatic cancer is very deadly and it's almost late stages when it's identified. How early do you think this can potentially lead?
That's a really great question, and we're going to talk about it in the next section, but I can talk about it a little bit. So we do analysis. We define a CT scan called pre-diagnostic CT scan, which means if you take a patient that diagnosed by today, we take 3 to 6 months before today, that radiologist, they take scans, but radiologists don't think they do have pancreatic cancer. We extract those CT scans and test our AI model on that. And the median time about how AI can diagnose earlier than radiologists about 1 year. So 1 year before we found the pancreatic cancer. We will talk about this in the session I just talked about.
All right, so another reason to stay after this one too. Thank you.
Thank you so much.
Great, thank you. All right, we have